Gila.
Thanks, Warren. Good morning, everyone. I first want to start by acknowledging that we're here on Coast Salish territory, and I think as I expand a little bit more, that might become a little bit clearer as to why I'm making this acknowledgement. I'm going to talk to you this morning about how is it that the Canadian Guidelines on Sexually Transmitted Infections sees MSM as infected deviants. I mean, that's pretty strong language to begin with, especially at 9 o'clock on a Friday morning. I argue that it's done through surveillance, quarantine, and the death sentence. Even a little bit harsher language. So you'll probably think I'm a wingnut, and that's okay, but I'm going to try and show you how I came to these conclusions when I read the MSM guidelines. So I'm talking specifically about a piece of policy, and a policy that guides healthcare practitioners to assess people in general for HIV and STIs. I conducted a discourse analysis on the Canadian Guidelines of Sexually Transmitted Infections. That's the piece of policy that I'm looking at. And for this presentation, I'm specifically looking at the MSM appendix that's attached. And very specifically, I'm looking at the epidemiology section of that particular appendix. So my discourse analysis was informed by Foucauldian thought, feminist post-structuralism, critical race theory, as well as gender and queer theories. For me, when I was looking at epidemiology, I really saw it as a form of biopower. And so I'm going to try and explain this in very concise point. Biopower is a Foucauldian term that's used to expose how power works to construct both the individual and the population. So for those of you who are familiar with epidemiology, you understand that we talk about the population and try and measure things about the population. But it also works on the level of the individual. So we're looking at a micro level as well as kind of like a macro level. So biopower suggests that the individual is surveyed, normalized, and disciplined, whereas the population is controlled, medicalized, and regulated. Chambon, Irving, and Epstein say that biopower is a conceptual tool that makes it possible to analyze historically how power has come to work in relation to the human body. Sexuality is at a privileged intersection between the individual and the population. It is a target of self-knowledge and the essential means to regulate the reproduction of a population. For me, I started to see how biopower and epidemiology mirror each other in a lot of ways. They match up. Individuals and populations. They give rules about behavior, and they talk about how individual actions have implications for the whole population. So I think it's important to remember that HIV wasn't always a reportable disease. For those of you who remember, how we approach HIV epidemiology is a lot different than it was about 10 years ago. For those of you who remember, in about May 2003, HIV became a reportable disease across all of Canada. And at that point, medical associations as well as AIDS service organizations had a lot of concerns about HIV becoming a reportable disease. There's problems around reportability. Different provinces have different ways of reporting. Some of you may be familiar around nominal, non-nominal, and anonymous testing and the challenges that those pose and the risks that they pose. It raises concerns around, I argue that while reportability of HIV is not a hot topic any longer, it's still a significant concern in terms of breaches of confidentiality that still continue to happen and lack of informed consent that also happens. At the end of the day, how is surveillance actually used? What is done with this information? I argue that by making HIV a reportable disease, it led to the increased surveillance of HIV. So when we talk about epidemiology as biopower, I think about David Halperin's words, which are public discourses about the return of unsafe sex practices have contributed to the repathologizing of homosexuality. I don't know about you, but when I think about barebacking, I certainly think about these guys. Respectable guys riding their bikes in the park, same outfits. Definitely what I think about when I think about barebacking. So for me, I had to explain how does power work through epidemiology, and there's three kind of ways that I looked to do that. One was by interrogating the truth claims that were made in the epidemiology section. So some of you may have read it, some of you might be familiar or aware of the recent outbreaks of syphilis within the MSM communities. I read this through, didn't think anything of it. Read it through again, didn't think anything of it. Read it through, thought I should look at those references if I'm doing a discourse analysis and try and find out where this information came from. And I found that all of the sources were American. Surprising, Canadian guidelines, American sources. So I started to look up Canadian epidemiology around syphilis outbreaks and found that there were significant outbreaks within hetero communities, and yet MSM were highlighted as the infected ones. STIs become synonymous with MSM and sexual deviance. We expect that MSM are diseased. So the second way that I looked at how power works through epidemiology is by looking at how acts of deviance are conflated. So by that, they talk about MSM in the guidelines. They talk about how MSM have sex, where they have sex, who they have sex with, how often they have sex with. So there's like this long list. Unprotected anal intercourse, otherwise known as barebacking, increased number of sexual partners, partner finding on the internet, anonymous sex partnering venues, recreational, non-recreational drug use, unprotected oral sex. This list is exhaustive and exhausting. And it's hard for healthcare practitioners who are reading these guidelines to not find these acts overwhelming and to leave little room to not conflate these sexual deviant practices with MSM. This discourse is clearly seductive and effective. The third thing that I did was I looked at exposing what remains invisible. MSM epi isn't contextualized, and therefore heterosexuality remains seemingly out of reach of epidemiology's gaze and regulation. Heterosexuality remains normal and situated in that way from which MSM have deviated. So I think that this picture is particularly interesting if we think about it in terms of a critical race analysis around how this white body is human and this black body is inhuman and dangerous. And if you ask me questions about that later, I'll tell you. But I just want to flag that for you there. Because I think that when we talk about unsafe sex practices, which comes up a lot in the guidelines, it refers a lot to the criteria or what we think of in terms of harm reduction strategies. But what I ended up finding was that abstinence-based thinking is actually permeating these guidelines a little bit more. So when is it okay for MSM to not use condoms? Anytime? We're not allowed to use, we don't have to use condoms anytime? No. The answer, right, is that MSM are never allowed to use condoms. Or should always use condoms, sorry. Now you have me all flustered. Heteros are always expected to not use barriers when they're trying to breed, but it's never advised for queers to not use protection. So there's also problems with what we conceive of as unsafe sex practices. Carlos de Sena talks about how non-disclosure of sex partners is a flawed, unsafe sex practice. The intended consequence of disclosing one's male sex partner to one's female sex partner is to quarantine MSM of color from heterosexuality. Similarly, HIV-positive MSM are supposed to disclose their HIV status with the intended consequence of quarantining them into celibacy. So what's supposed to happen here, right? HIV-positive guy tells his partner or his potential lover that he's HIV positive. The intended consequence is that the potential lover turns around, runs, and possibly even outing him. The intended consequences of both of these types of disclosures are to quarantine both MSM of color and men living with HIV. Quarantining people is one of the original tenets of AIDS phobia. I also found within the guidelines this discourse of living longer. The guidelines refer to the Ontario Men's Survey and cites that, quote, an increased unsafe sex practice among HIV-infected MSM has been attributed in part to an increased proportion of HIV-infected MSM who feel healthy, are living longer, and therefore having more sex more often with more partners. While no doubt heart has been instrumental in shifting HIV to a manageable chronic illness, this discourse is still premised on the idea that people who have HIV should be sentenced to death. The discourse of living longer also negates how class, race, and colonialism have worked to keep HIV a death sentence for some people. Indigenous people are grossly overrepresented in HIV statistics. As you can see here, Aboriginal people comprise 3.8% of the population, and yet they comprise 9% of newly diagnosed as of 2006. Again, as of 2006, Aboriginal people comprise 24.4% of all people living with AIDS. So clearly, the discourse of living longer has limited positive impact on Indigenous people living with HIV and AIDS. So for me, HIV epidemiology conflates MSM with disease, and I see that as us ending up back at GRID, the gay-related immune deficiency syndrome. I saw that infected deviants were constructed through cumulative sites of marked deviants as well as a rejection of imposed abstinence. So at the end of the day, what are we left with? For me, these discourses stabilize heteronormativity, they continue to normalize colonialism, they perpetuate AIDS phobia and homophobia, and they promote surveillance, quarantine, and the death sentence. And I'm left with further questions about how has the study of disease become about controlling and regulating individuals and populations, whose bodies are marked by disease, and what are the implications of these markings? Thanks.